Hello everyone, today I'm going to be talking to you about NASH, the long-term killer. My SMART goal is to identify the causes, symptoms, effects, and treatments for NAFLD and NASH within a 10-minute presentation. I reviewed and summarized 8 articles over the span of 7 weeks. My objective with this presentation is to showcase how lifestyle changes and drug therapy can affect these illnesses. So what is NAFLD and NASH? NAFLD and NASH are abbreviations for non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. NASH differs from NAFLD because it is associated with inflammation and liver cellular death. According to the Canadian Liver Foundation, NAFLD occurs in about 20% of Canadians. NAFLD and NASH are known complications for obesity. Obesity leads to increased storage of fat in the liver and an enlarged liver. NAFLD can develop when the amount of fat that accumulates in the liver is greater than 5%. Again, NAFLD, non-alcoholic fatty liver disease, may progress to NASH, non-alcoholic steatohepatitis, which can further progress to fibrosis of the liver, which is scarring of the liver. So let's talk symptoms. Symptoms of NAFLD and NASH can be tricky to identify. According to the Canadian Liver Foundation, and I quote, in general, people with fatty liver disease have no symptoms. However, some people report discomfort in the abdomen at the level of the liver, general feeling of being unwell, and vague discomfort. So why is NASH a big deal? NAFLD is usually asymptomatic. If the condition persists, NAFLD can progress to the clinically more severe condition, which is NASH. NASH can be identified by the abnormal liver tests such as ALT. NASH can lead to cirrhosis and liver failure. It can also lead to hepatic carcinoma or liver cancer. NASH is one of the leading causes for liver transplants. So why is this topic relevant? This topic is relevant because there's a positive link between being overweight/obese and developing NAFLD or NASH. In 2018, about 30% of Canadian adults were obese or overweight. Patients with NAFLD and NASH have special considerations when exercising, like plyometric exercise may be prohibited. The clients will be looking for a weight loss oriented exercise prescription, and the client is likely deconditioned. However, there are exercises that positively affect NAFLD and NASH, which we'll talk about later in the presentation. So now let's talk about modeling data. Between 2018 to 2030, NAFLD is estimated to increase in Canada by 20%, which is 9,305,000 cases, and NASH is estimated to increase by 35% to 2,630,000 cases. Now, treatment. There are numerous approaches for treatment of NAFLD and not so many for NASH. These treatments are categorized into sections. So let's begin with dietary intervention. In this category, we're going to talk about two interventions. The first one being time-restricted feeding, or TRF. The point of TRF is to reset our circadian diet. There is a recent study that investigated NAFLD and TRF and found that weight loss was achieved as well as decreased triglyceride levels over a 12-week period when compared to the control group. The second intervention is caloric restriction. There is a positive link between excessive caloric intake and obesity. As I said earlier, obesity is a leading risk factor for NAFLD. Also, carbohydrates have been linked to development of NAFLD. It is recommended to restrict carbohydrates, but why? Carbohydrate restriction diets decrease glycemic load and decrease insulin resistance and pancreatic beta cell secretion. So what this means is insulin penetration increases, which creates less of a demand in insulin production in the pancreatic cells. They also increase HDL and reduce serum triglycerides. In one study, a hypocaloric low carbohydrate and low-fat diets, so 40% and 45% respectively, significantly reduced ALT and serum insulin. So now, pharmacological therapy. Pharmacological therapy are using drugs to treat NAFLD and NASH. In this category, there are 5 subcategories, but we're only going to touch on a few in detail. The first drug I'm going to talk about is pioglitazone. The PIVENS trial found that pioglitazone cured steatohepatitis more frequently than the placebo group in a 2-year observation period. Another insulin sensitizer is semaglutide. Semaglutide yielded an exceptional higher resolution of NASH compared to the placebo group in a double-blinded 72-week trial. However, there was no improvement in liver scarring. Again, fibrosis. So vitamin E is another useful drug. It can prevent oxidative damage caused by free radicals. An RCT study found that vitamin E resulted in a 36% reduction of NASH for patients who received vitamin E. Side effects of vitamin E include mortality from hemorrhagic stroke and prostate cancer. Now, bariatric surgery. Bariatric surgery is a more invasive approach to weight loss. The reason some patients turn to bariatric surgery is due to the difficulty of both losing weight and maintaining their weight loss. Bariatric surgery is currently recommended for patients that have a BMI of equal to or greater than 40 with no comorbidities, or a BMI between 35 to 39.9 with serious comorbidities. For example, NAFLD and NASH. Patients with NASH who have had this procedure show significant improvements in steatohepatitis and fibrosis. Complications to this procedure include nutritional deficiency, hyperinsulinemia, and hypoglycemia, to name a few. Gut microbiota. As we all know, the gut microbiome refers to the ecosystem of bacteria in our gut. Fecal microbiota transplant, or FMT, is the procedure of repopulating an unhealthy ecosystem with healthy fecal matter. FMT is currently under consideration for NASH and possesses potential as a therapeutic method. Now let's talk about exercise. In all the articles that touch on the topic of exercise, there was one conclusive answer. Exercise is a good way to combat being overweight or obese. However, there are conflicting findings about the effect of exercise intensity when dealing with NAFLD and NASH. One article concluded that they were not sure what optimal intensity will decrease the hepatic fat found in the liver. They did say that longer exercise duration will likely help in lowering the process of NASH. A later article stated that exercise can decrease the probability of getting NASH. They found that it is possible to lose hepatic fat without losing weight. That means patients would lose visceral adipose tissue and lower free fatty acids in the plasma. In terms of intensity, they suggest vigorous activity is more effective with NASH and fibrosis than moderate activity. Now, the Canadian Liver Foundation refers to the CSET guidelines. They acknowledge the importance of physical activity and that exercise should be the first lifestyle modification. The Canadian Physical Activity Guidelines, as we all know, prescribe a cumulative 150 minutes per week of moderate to vigorous aerobic activity, as well as muscle conditioning for bone health. However, obese individuals are often very sedentary. The first goal is to get these individuals up and moving and doing something that is physically demanding. They suggest brisk walking and bike riding for moderate intensity. Vigorous intensity activities include jogging and cross-country skiing. It is important to increase activity gradually to avoid injury. NAFLD is a more treatable condition than NASH. There are several treatments in their infancy stage that show promise for NASH. Both conditions can be managed through increased exercise and nutritional diet that reduces caloric intake. Thank you very much for listening to my presentation. My name is Henry Kaplan, and I look forward to your questions.